Hope Rugo, breast medical oncologist at the University of California, San Francisco, and the safety officer for the multi-center randomized phase 2 I-SPY2 trial. Really very interesting, forward-thinking, adaptively randomized trial evaluating novel therapies as neoadjuvant treatment for patients with high-risk early-stage breast cancer. So in this trial, we actually obtain tumor samples for patients who have high-risk early-stage disease, and then we treat them with a variety of different therapies, and these types of therapies change sequentially over time as agents graduate for either being more effective or similar to the standard therapy options. We do this because we're trying to find better ways to treat breast cancer and to reduce toxicities and to improve the outcome for patients. In some situations, this might allow patients to get less therapy overall, which is also really exciting. But when we know a treatment isn't working, we might be able to give a better treatment that works for that type of disease. So what we did here was, in the light of trastuzumab deruxtecan, or T-DXd, having remarkable efficacy in metastatic HER2-low disease, we looked at what HER2-low meant in our patients on I-SPY. We have the tumor samples, we looked at the initial core biopsies, and what we saw, which has been shown before, is if we look at patients who have hormone receptor-positive disease, the HER2-low group is more common than in patients who had triple-negative disease. And we had a big subset, 585 patients, overall about 63%. The HER2-low in our triple-negative group is higher than what has been observed in some other studies, including in the early-stage setting, and it may be relative to the population that's identified in I-SPY. Patients who go on to I-SPY who have hormone receptor-positive disease have to have mammoprint high-risk disease. We looked at the relationship between high 1 and high 2, so this is on the lower end of the high scale and the higher end of the high scale, and what we saw was that it didn't really make a difference. There wasn't an association between the higher or lower scores within mammoprint high risk. Then we looked at endocrine sensitivity using something developed by Fraser Simmons at MD Anderson, the SET index. We also found no association with endocrine sensitivity, SET high or patients who have more endocrine sensitive disease, SET low, less so. Then we looked at something actually developed at UCSF by my colleagues Christina Yao and Denise Wolf called the response predictive subtype. That test is now being done as imprint and reprint through mammoprint, through Agendia, and is part of our testing for investigative purposes in I-SPY. So what we found was quite interesting. When we looked at the patients who had, these are all HER2 negative tumors, when we looked at the patients who were immune negative and DNA repair, or DRD negative, we found that there was more overall HER2 low disease. And then when we divided it into hormone receptor positive and triple negative, no real difference in triple negative, but in hormone receptor positive disease, there are more patients who are HER2 low who have this immune negative, DRD negative gene expression type. And those patients tend not to respond to standard therapy very well. We have low PCR rates. So this is a good group potentially to target with a drug that works really well in HER2 low disease, like trastuzumab deruxtecan, or other drugs in the future. So that's of course our goal. We looked to see whether or not having HER2 low versus zero disease made an impact on pathologic complete response, or PCR, and it didn't make any impact at all. Patients who had HER2 low disease or HER2 zero who had a PCR did very well. Those patients who did not have a PCR had a worse outcome. But although that looks like there's a little bit of a separation here between HER2 low and HER2 zero, this could largely be explained by the fact that there's more patients with triple negative disease who are HER2 zero, who have basal-like disease that doesn't respond to therapy, and those patients have a very poor outcome. So it's really not related specifically to HER2 low, but more to other biologic phenotypes. So we're really excited about that data and the possibility of using this to then apply new treatments that target HER2 low.